Mr. Chairman, dear colleagues, thank you very much for the invitation to this very interesting meeting. My task today is to give you some highlights about the ARRHYTHMIAS reports at the last ESC meeting. So I will speak about data that may change the clinical practice, and in particular I will focus on atrial fibrillation. We will see something about radiofrequency ablation, cardiorespiratory fitness, and oral anticoagulation in the real life. And then we move to the device stuff, and in particular I will show you something about leadless spacing, subcutaneous defibrillator, devices and the interaction with the environment, CRTD or CRTP, and finally we finish with the lead extraction. So let's move to the atrial fibrillation topic, and let's see if there were presented data to say how can we maintain the sinus rhythm in our patient. In London was presented the long-term result of the MANTRA paroxysmal atrial fibrillation trial that compare radiofrequency ablation to antiarrhythmic drugs for the first-line treatment of paroxystic atrial fibrillation. And they showed that in the long-term follow-up showed that the harm that was in the radiofrequency was for radiofrequency ablation with a follow-up of 5 years had an arrhythmia burden lower than the harm in treated with antiarrhythmic drugs. And in particular, in this harm, the patient were freed from any atrial fibrillation with an absolute risk reduction of -15% as compared to the antiarrhythmic drug. And this is the first study that show that radiofrequency ablation is superior to antiarrhythmic drugs for the maintenance of sinus rhythm over 5 years follow-up, and we have to remind you that this is for patients with paroxystic atrial fibrillation. And there was also an abstract in London that was presented in which the author showed that atrial fibrillation recurrences in obese patients treated with antiarrhythmic drugs or ablation was compared by gain in fitness in terms of METs and baseline fitness levels over 4 years. And surprisingly, they showed that total arrhythmia freedom was higher in those who gain more than 2 METs. And in particular, 85% of the patients treated for atrial fibrillation who gained more than 2 METs were free from any arrhythmia at 4 years follow-up. And looking at the multivariable predictors, also they confirm that the low baseline fitness level, no METs gain, together with other well-known prognosticators as diabetes mellitus type 2 and no weight loss, predicted the recurrences. Therefore, which are the take-home messages from these two studies presented in London? That radiofrequency ablation is superior to antiarrhythmic drug to maintain sinus rhythm when given as first-line treatment in paroxystic atrial fibrillation. The success of atrial fibrillation therapy depends strongly on lifestyle, and lifestyle modification should be part of atrial fibrillation therapy. Then it was presented also the result of novel oral anticoagulation in real life. And in particular, the Xanthus study was a real-life data on adverse event in patients with non-valvular atrial fibrillation treated with rivaroxaban. The aim of the study was to assess rivaroxaban safety in an unselected patient with non-valvular atrial fibrillation, so in the real life. And it was an observational study with 1 year follow-up, and the primary outcome were major bleeding, death, stroke, and systemic embolism. More than 6,000 patients. The mean CHAT score was 2, and 80% of the patients were still on rivaroxaban after 1 year. And the event rates observed was very low. And in particular, if we look at the outcomes according to the dosing of these new drugs, new oral anticoagulant, so that can be given in two doses, the 20 milligram per day and the 15 milligram per day, major bleeding, all cause of death, and thromboembolic event were higher in patients taking 15 milligram, because those are the patients that are sicker as compared to the 20 milligram. However, the event rates in all the groups, in all the subgroups, were lower, and specifically, if we compare all the events that author observed in the Xanthus trial to the events observed in the rocket atrial fibrillation trial, that was the trial that validated the rivaroxaban, the events in the Xanthus observational study were absolutely lower as compared to the rocket atrial fibrillation, and also the patients were less sick because we have a CHAT score mean in Xanthus 2 and in rocket atrial fibrillation was 3.5. And specifically, if we focus the attention in gastrointestinal bleeding, that was the main criticism of rivaroxaban in the rocket trial, that was very high and was higher than warfarin group. In the real life, in the Xanthus, with less sick patient, the gastrointestinal bleeding is very low because it's less than 1%. So the conclusion is that this is the first large prospective study describing the use of a novel oral anticoagulant in a broad non-valvular atrial fibrillation patient population. And in this study, so in the real life, the patients are at a lower overall risk than in the trial, in the ideal trial build that was the rocket atrial fibrillation. And the rates of stroke and major bleeding with rivaroxaban were low in routine clinical practice. So now we move to the device staff, and in particular, for the first time in London was presented the leadless pacing. The leadless pacing was presented in an observational study with a 6-month follow-up, and in particular, in this study, the authors enrolled 300 patients and they look at the serious adverse device events and the efficacy of the device. The results were very good because we have an implantation success rate of 96%. Freedom from serious adverse event was in 93% of the people. Pacing performance was very good in terms of threshold, impedance, sensing, and the estimated battery longevity was estimated in 15 years, so very long. Which are the main drawbacks? This is just a single chamber device, cannot be a dual chamber device. The author does not explain clearly how to manage the battery depletion. What can we do when the battery is finished? We put another device, we remove the previous one. Which are the risks? We don't know. We need a large introducer, 18 French, to put this device in the apex of the right ventricle. Therefore, there is a not negligible risk of vascular complication. And also, if we look at the major complication, the risk was very high. And if we compare to the last Danish pacemaker registry, the risk of complication is double, because we have that major complication for pacemaker were reported in 3.3%, and in this trial was 6.5%. And also, if we extrapolate from the Danish pacemaker registry only the VVI pacemaker, so the single chamber, the risk for the standard pacing is even lower. And the risk for this leadless pacing is pretty high, because it's 6.5%. That is so far today is still high. So leadless pacing is promising for some patients, not for everybody, with an indication of VVI pacemaker, but still there is some work to do it. Then we move to the subcutaneous cardioverter defibrillator. This afternoon I will show you also that this device will be part of the new recommendation for the ventricular tachycardia guidelines. Anyway, this is a particular device that is completely out of the vessel. The lead is subcutaneous, so there is a tunnelization that makes the lead subcutaneous and not anymore inside the vessel. And in this way, we reduce the risk of endocarditis, we reduce the risk of vascular complication, and in particular, the new guidelines suggest this implantation in class 2A with level of evidence C in all the patients that they do not need any pacing, because with this device we cannot pace, and for the patient that they do not need also cardiac resynchronization therapy or anti-tachycardia pacing for the treatment of ventricular arrhythmias. And in particular, the subgroup of the patient that can have the best benefit from this device are the young people with upfront a long story of defibrillator. There are the patients that were recently extracted from endovascular catheter because of infection, patient without any access, venous access, or very difficult venous access. So the future perspective for the device is also to make a communication between leadless pacing inside the heart and the subcutaneous ICD in order to get sort of hybrid devices with the subcutaneous inside the left ventricle and the leadless pacing inside the left ventricle and the subcutaneous in order to have some resynchronization therapy that can have the pacing inside the heart and the ICD backup outside in order to reduce the catheter inside the left ventricle. Then some nice stuff, because there was also presented the result on the interaction between devices and the environment. And fundamentally, the authors confirmed that the actual devices, pacemaker or ICD, have a very low risk of interaction with household appliances, cellular phones. We just have to keep some attention, some distance when we are using these devices and our, for instance, cellular phones or whatever.